Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings. And this meeting is a special one because we are preparing for the holy month of Ramadan, and we are all asked about how to deal with from our patients and from our colleagues, how to deal with our patients, how to deal with myself during Ramadan fasting, and how to prepare myself. And this is the purpose of this meeting is to advance the knowledge about or raise the knowledge or discuss the topic of how to deal with our patients during Ramadan regarding two topics. Of course, kidney diseases, and the second topic is with diabetes mellitus, because we are all in the start are internists in addition to being a nephrologist, and we deal with our patients, diabetic patients and mainly, and hypertensive, etc. We choose these two topics to deal with our patients with kidney disease and diabetes in Ramadan. I would like to welcome moderators of this session who shall me the moderation of this session. Professor Ahmed Rifai, the president of Egyptian Society of Nephrology and Transplantation, and Professor Inas Shaltut, professor of nephrology, professor of internal medicine and diabetology in Cairo University, and the head of the president of Arabic Association of Diabetes and Metabolism, who recently published consensus guidelines for Ramadan fasting in the past month about recommendations of the Arabic Association of Diabetes and Metabolism regarding Ramadan fasting and dealing with diabetic patients in Ramadan fasting. So I will leave the floor for the two presidents, President of Egyptian Society and the President of ASD, to moderate this meeting and introduce the speakers. Our speakers, Professor Ahmed Elkeraie, Head of Nephrology Unit in Alexandria University and Professor of Nephrology and Internal Medicine, and Professor Hosam Ghazi, Professor of Nephrology and Internal Medicine in Mansoura University. So please, Professor Ayman. Professor Ayman Rifai. Dr. Ayman. Unmute yourself, please, Professor Ayman.
Okay, I was unmuted by the
Okay.
Welcome. Thank you very much, Professor Yasser, for this timely important topic. And actually, although the mercy of our religion, Islam, that patients have the permission not to fast according to the medical advice, yet most patients express their desire to fast during Ramadan, and they are very broken when their physician informed them not to fast. And nephrologists every year are asked by their patients whether they can fast Ramadan or not. And unfortunately, there is no strong evident answer for this repeated question. And all advices given to patients are largely based on the individual basis and nephrologist experience due to the lack of large cohort in this topic. So it's my pleasure to introduce tonight a dear brother and friend and colleague, Professor Ahmed Elkeraie, Professor of Internal Medicine and Nephrology, and the head of Nephrology Unit in Alexandria University. And I think he's going to highlight this issue and provide advices both to the clinician and patient as well, and to review some of the most recent studies regarding the effect of Ramadan fasting on patients either with CKD, hemodialysis, or renal transplantation. So please, Professor Ahmed.
So please, Professor Ayman, Professor Inas. Professor Ines will welcome. We want to welcome her, and she wants to welcome us and Professor Hosam Ghazi. اتفضلي
It's
دكتور
my
إيناس.
pleasure and honor actually to co-moderate this session with Professor Ines Shaltut, one of the Egyptian and Arab and world figure actually in endocrinology and diabetes. Welcome, Professor Ines.
Thank you very much, Professor Ayman Al-Rifai. It's my pleasure to be with you in this important session today, together with Professor Ayman Al-Rifai, Professor Yasser Abdelhamid, Professor Ahmed Elkeraie, and Professor Hosam Ghazi. The second lecture will be about diabetes and Ramadan, and I endorse your speech, Professor Ayman Al-Rifai, about people with diabetes trying to fast. In one of our studies, we found 98% of people with diabetes, they wish to fast and they insist to fast, and most of them complete Ramadan. But according to our Holy Quran, Bismillah ar-Rahman ar-Rahim, yuridu Allahu bikum al-yusr wa la yuridu bikum al-usr. صدق الله العظيم. بسم الله الرحمن الرحيم. ولا تقتلوا أنفسكم. صدق الله العظيم. So our association, Arabic Association for the Study of Diabetes and Metabolism, really worked hard for 2 years to have a consensus called risk stratification in people with diabetes for fasting during Ramadan, a consensus from Arabic Association for the Study of Diabetes and Metabolism, and it is recently published in the Current Diabetes Review, which is an important journal. I invite all our audiences today to check this publication and to benefit from the effort of many professors worked for a whole 2 years. We are going to have the second presentation, Diabetes and Ramadan, with Professor Hosam Ghazi. Then we're going to have the discussion on diabetes later on. Thank you very much.
Thank you, Professor Ines. I would like, before we go to Professor Ahmed Elkeraie, as introduced by Professor Ayman Rifai, to thank Dr. Rami Abu Bakr, who is the moderator today. Thank you, Dr. Rami, for your work with this session and all of your very useful and helpful work in CME chapter during the past 3 years. Please, Professor Ahmed Elkeraie, Professor of Nephrology, Internal Medicine, Alexandria University, and the Head of Nephrology Department in Alexandria University and ESNT Board member. Please, Professor Ahmed, start.
السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم، وأشهد أن لا إله إلا الله وحده لا شريك له، وأشهد أن محمدا عبد الله ورسوله. اللهم بلغنا وإياكم رمضان وأعنا فيه على الطاعة وتقبل منا ومنكم. Thanks everyone for the nice introduction and for the nice discussion aforehead. And you've made my life easy during the forthcoming 30 or 45 minutes or so. Really, there is no yet a general consensus. Really, there are insisting patients who insist to fast in spite of medical advice. And really, we don't know what is the appropriate thing to do in many situations. And finally, yes, it is for expert opinion rather than for guidelines, recommendation, or even suggestion. So this is the bottom line. We're going to dig through what is available from the scarce literature, and we're going to find out what could be the rationale. And as well, we're going to open the door for the completely opposite point of view, which is a challenging point, and I would recommend to have this as a pros and cons in the very next meeting of our society and the other societies. Could fasting be helpful sometimes? We will discuss that especially in the view of the plethora of literature of the usefulness of intermittent fasting in many aspects of diseases. So let's start. First, we'll try to cover these points: chronic kidney disease and fasting, kidney transplantation patients and fasting, dialysis patient, whether hemo or peritoneal dialysis, patients with systemic lupus who unfortunately have almost no data at all, polycystic kidney disease, what as a specific or peculiar type of kidney diseases, what can fasting do with them? And lastly, what drug management or medicine management that we should do. And as Professor Ayman earlier mentioned, we will end that by some advices to the patient through a patient education program that have been done by our colleague, clinical pharmacist, Dr. Rami Al-Warraqi. First, as we all know, the very famous verse in Surah Al-Baqarah, قول الله تعالى شهر رمضان الذي أنزل فيه القرآن هدى للناس وبينات من الهدى والفرقان فمن شهد منكم الشهر فليصم ومن كان مريضا أو على سفر فعدة من أيام أخر يريد الله بكم اليسر ولا يريد بكم العسر ولتكملوا العدة ولتكبروا الله على ما هداكم ولعلكم تشكرون. So in the very same verse that Allah subhanahu wa ta'ala mentioned that fasting Ramadan is timely mannered by the time of the Ramadan and by the direct vision of the hilal of the month, Allah subhanahu wa ta'ala mentioned that there are exemption from fasting, and this exemption can be by replacing for other days. And this verse is the scientific evidence that we rely on while speaking to our patient who insist to fast in spite or against the medical advice. There are Islamically exemption from fasting, and these are the frail and the elderly, as قول الله تعالى وعلى الذين يطيقونه فدية طعام مسكين. And the scholars have mentioned that there is لا مقدرة, which means وعلى الذين لا يطيقونه فدية طعام مسكين. وهذه من لغات العرب المعروفة, that you skip a letter that is understood by common sense. So the meaning of the ayah وَعَلَى الَّذِينَ يُطِيقُونَهُ فِدْيَةٌ, that those who cannot tolerate fasting, they can give the fidya or the ransom for the breaking of the fast by feeding a poor person for each day. So frail and elderly are exempted from fasting, as well as children, of course, before reaching the puberty, and the travelers whom are traveling more than 82 or 83 kilos or 50 miles, those with acute illness, pregnant and breastfeeding women, and those who cannot understand the purpose of fasting, like with IQ difficulties. And when Allah subhanahu wa ta'ala mentioned, and this is a cornerstone while you are addressing the subject of iftar during Ramadan for those whom are medically ill, Allah subhanahu wa ta'ala said, فَمَنْ كَانَ مِنْكُمْ مَرِيضًا. In Arabic language, when you come with the noun in the tense of an-nakira, you know that you can define by al, like you said, al-marid. Al-marid, so this is a specific person. But when you say marid, so this is nakira, والنكرة في سياق الكلام تفيد العموم. هذه قاعدة من قواعد اللغة العربية. So فمن كان منكم مريضا, so any patient, any ill person to the extent that the scholars said that people with headache or toothache are in the world of marid, so they can be exempted from fasting. And this is an important point, and the other issue that you should rest on while talking to your patient, and these are important aspects to talk to your patient from a religious point of view, because many of the patients would take that fasting is a religious aspect, and doctors are somewhat careless about giving them the advice per religious aspect, and they only give the advice per medical aspect. So they choose not to follow the doctor's or the physician order or advice because they thought that they don't understand the proper religious pathways. And this is totally wrong. You have to prove to your patient that you are speaking from both medical and religious aspect. You have a license to break your fast because Allah subhanahu wa ta'ala said, فَمَنْ كَانَ مِنْكُمْ مَرِيضًا, as we mentioned, is nakira, تفيد عموم المرض, and because Allah subhanahu wa ta'ala in the hadith of the Prophet sallallahu alaihi wasallam, إِنَّ اللَّهَ يُحِبُّ أَن تُؤْتَى رُخَصَهُ كَمَا يُحِبُّ أَن لَا تُؤْتَى مَحَارِمَهُ. So Allah subhanahu wa ta'ala likes that people take the permissions that He gave them, subhanahu wa ta'ala. So you have to stand fast from this point to your patient so that you can persuade them to break their fast. There are people who should not fast, and you'll find through the categories of the classification of the patient that there are patients should not fast and patients who must not fast, and the patient can fast. And this is, in a way or another, the classification. And for those who should not fast is type 1 diabetes mellitus, and of course we're going to hear about that in the next lecture. Those with severe cardiac and pulmonary conditions, those with active GI bleed and acute ulcers, those with severe epilepsy, and those with severe migraine as well, and those with unstable CKD, unstable renal transplant function, or those with nephrolithiasis and repeated UTI. So those types of patients should be exempted from fasting initially. Let's go through Ramadan and kidney diseases and look for what is there from the literature. This might be, and these have been put forward by Professor Hisham Sayed a couple of hours ago on many of the groups that contains most of you as candidates. And this is the IDF diabetes and Ramadan risk categories. As you can see, classification is into low and high and very high risk. And for the low risk, you advise the patient to listen to the medical advice, and this involves those patients with CKD from stage 1 through stage 3, even 3B, but with stable kidney function. So it's not only the stage, but it is also the let's say the rate of progression of the kidney disease or the stability of the progression of the GFR. Other groups in this low moderate risk are CKD patients prone to urinary tract infection or stone formation, and these should listen to the medical advice because according to the situation of the type of UTI, whether upper or lower, the frequency of repetition, the need for good hydration, as well as the same for nephrolithiasis, whether this is a genetic mediated type like cysteine deficiency and others, or primary hyperoxaluria and others, or a patient with advanced repeated bilateral kidney stones who necessitates 4 to 5 liters of oral fluids per day and abundance from long interval of avoiding of drinking, the advice would be given. So these should listen to the medical advice. For those patients who are at high risk and should not fast are those with stages 1 to 3, but with unstable kidney function, or those CKD patients with non-electrolyte abnormalities, risk of dehydration due to fluid restriction, or patient on ACE inhibitors, ARBs, maybe as GLT2 inhibitor, maybe yes, maybe not, as also have been posted by Professor Hosam, the elegant paper by Professor Magdi Sharqawi and colleagues, and people with mineralocorticoid receptor antagonists. Again, all these type of patients are to be very highly considered to break their fasts. But on a special occasion, on a special types of patients who are on these drugs for a long time and are very, very much stable, and for duration of fasting that might be like 13 hours or less, like Ramadan in this year and the forthcoming years, you might consider that they can fast under very specific monitoring and situations and conditions. The third category are people that must not fast, and these are the very high risk category, like those stage 4 to 5 on non-dialysis, 5 non-D, and patient on all forms of hemo and peritoneal dialysis, and this is a much questionable point. That's why we are actually admitting that we don't have a good consensus yet, because this is against the common practice that we allow patients on hemodialysis to fast on regular basis, and this does not affect them. Maybe a special precaution would be to patients on incremental hemodialysis, but those on regular hemodialysis, thrice weekly, prevalent patient for more than 6 months or 1 year, stable, as was earlier said by Professor Hosam, they might even do better on hemodialysis because of the restriction of the fluid that would help those anuric patients to limit their intradialytic weight gain. And the problem would be with the type of food that they ate during, or they eat during Ramadan, not due to the fast itself. Definitely people with stage 3 to 5 with a history of pre-existing cardiovascular disease, that's to say a comorbid condition, patients on tolvaptan, as you know, the vaptans are aquaretics, and these are not suitable to be taken with fasting, and definitely pregnant CKD patient, because after all, we initially ask a pregnant woman to break her fast, even if she's okay, but some of them still can fast if they can tolerate and there is no risk. But definitely if she's pregnant and she's CKD of any degree, you should prohibit her from fasting. And this paper, published almost 2.5 years ago, showed the effect of fasting on chronic kidney disease and the pathway when a patient wishes to fast. You would first ask the patient, is he intending to fast or not? And if he is not intending to fast, you would continue with his current treatment, and you have to assure him that as long as he is a patient, he has no offensive done, or a sin, or something haram that he is doing because he is breaking the fast during Ramadan, because he is, after all, marid. If he insists on fasting or he wants to fast, you have to explore the patient risk stratification. If he is low or moderate risk, you would allow him to fast with a special precaution. Actually, monitoring the patient during fasting Ramadan and the precaution you are taking with him is very much variable according to expert opinion, from a person to person, and from a physician to physician, and maybe tailored as well according to the type of the patient and the stage of the disease, as we will see later. If he's a high risk or a very high risk, explore alternative options. And this, again, is another important point. It's much easier to tell the patient, oh, please don't fast Ramadan. And then when we are in January or December, when the daytime is 12 hours, you can substitute this, as Allah subhanahu wa ta'ala said, فَعِدَّةٌ مِّنْ أَيَّامٍ أُخَرٍ. So you can replace these days of Ramadan by other days, and you also have the option not to fast them repetitively. You can fast like 2 days a week, 3 days a week, 1 day a week, or whatever, over a long period of time. So you would tell the patient that you can have musta'tab, you can have another option that you can do later on in winter, or even you can give the fidya if you have a what we call a disease لا يرجى برؤه. It's a chronic illness that you are not expected to be cured from, so you can give the fidya instead of replacing those days. If the patient still choose to fast, actually this is another point that we have to admit. I'm sorry, it might be a lot of advocative and advices to the physician of how to deal with the patients in different situations, but this is the real life that we need. Whenever your patient is insisting to fast, sorry, don't tell him, okay, go to your whatever you're going to do, I'm not going to treat you, I'm not responsible, you're going to have renal failure, you're going to end up on dialysis. You're not allowed to do so. You have to advise him, and you have to insist on your advice, and you have to explain to him that what he's doing might be haram because he is doing some harm to himself according to the best of our knowledge. But if you insist, after all, to fast, because as was mentioned earlier by the colleagues, sometimes people, especially old people, when you tell them, they might be, by the way, not so much religious, but when you tell them that you cannot fast, they feel like this is the end of their life. I'm being on fasting since I was 7 or 8 years old, and now I'm 80 years. You're going to tell me not to fast? I better die. And people express it in the very same way. They feel that this means that they are too ill once and for all, and they want to die. So you can tell him it's better not to fast. This does not mean that you are in so bad condition or so, but this is to prevent further damage to your kidney. And Allah subhanahu wa ta'ala told us, وَلَا تُلْقُوا بِأَيْدِيكُمْ إِلَى التَّهْلُكَةِ وَقَالَ تَعَالَى وَلَا تَقْتُلُوا أَنفُسَكُمْ إِنَّ اللَّهَ كَانَ بِكُمْ رَحِيمًا. So the meaning that you have to tell the patient, don't do that. This is what Allah subhanahu wa ta'ala wants from you, and this is better for you. But if he insists, after all, you have still to take care of him. Like exactly when we say that you are going to take care of the patient who refuses dialysis in spite of the need for dialysis. You're not going to tell him, so go and die. You're going to manage his hyperkalemia, his acidosis, his volume overload by the maximum that you can do. So the same we'll do with the patient who insists to fast. We're going to do repeated tests, maybe twice a week, maybe once a week, maybe once every 5 days, according to his clinical situation. And you might convince him when he sees after a couple of tests that his rising renal function is going on and on, he might get convinced and he stop fasting. So this is an important point to follow up. You still need to give him the proper advice about the change in the medication and to follow up exactly like the patient that you allowed him to fast initially, as we're going to see later on. Fasting trial is another important point that we can do. like in month of Sha'ban. كان رسول الله صلى الله عليه وسلم لا يستكمل صيام شهر قط إلا شهر رمضان وكان لا يصوم في غير رمضان شهر أكثر منه في شعبان كما قالت سيدة عائشة رضي الله عنها. He had never fasted a whole month except for Ramadan, but he was the most fasting apart from Ramadan is in Sha'ban. So you can allow your patient to fast in Sha'ban few scattered days and monitor, like for example fasting the 3 days of the lunar days, the mid days of the Arabic month, and you would again test for the GFR and the rate of decline and any adverse events that happened. And if it passes well and good, this will encourage you and the patient to have a trial during Ramadan by fasting the first week and then reassess, and if things are okay, then the second week and reassess, and so on and so forth. Again, we just mentioned that he can fast during winter when Ramadan is in winter, like those days, or that he can replace the days later on. So let's start with our specific patient situation. First, CKD patients. Actually, we don't have a strong guidelines to advocate who and who should not, who should and who should not, or who could and who should not fast during Ramadan. It's very controversial. There are several factors like duration of fasting, presence of comorbid condition, CKD stage, and stability of stage over the past 6 months, guidance by healthcare providers, and the design of the existing studies. All these gives a lot of hassle about the recommendation that can be done to the patient during Ramadan. For example, the studies that have been published from Middle East and Egypt and was done during the study of years where Ramadan was 16 hours of fasting is not applicable when Ramadan is 12 hours of fasting, and during winter and in a cold weather like in Scandinavian countries, for example, sometimes you can have, because it's not an absolute, sometimes you can have Ramadan in some countries during winter like 8 hours or even less. Of course, you wouldn't prevent the patient from fasting because these are the same time that he is sleeping on every day. So in such a situation, it's not a problem. On the other hand, sometimes you might have Ramadan like 16 to 18 hours or even more. And this can be very tedious, and you have to insist upon your patient that he cannot fast, whatever the situation is. So these are some of the proposed guidelines that people with a stable CKD till stage 3 can fast. Stage 4 and 5, usually we don't allow them to fast because they are at high risk of complication, mainly progression of the CKD. Again, if the patient still to insist to fast, you have to educate him for the risk and take care of him and monitor. When fasting, this should be discontinued. And this is another important point. And actually, there is no specific trial that addressed this point, but this is an extrapolation from maybe the trials of RAS blockers, maybe the trials of SGLT2, maybe the common sense. When you allow a patient to fast, you would give him like 3, 5, or 7 days according to his situation, and then you would reassess the renal function. People might say if GFR declined by 25 to 30%, others would say if serum creatinine increased by 0.2 to 0.3 milligram per deciliter, which is above the cutoff for the lab threshold to have a minor error or whatever, you would tell the patient to break his fast. And this might be an accepted scenario, although there is no consensus. Definitely, if there is a major electrolyte disturbance, like sodium or potassium or phosphorus, you would allow the patient to discontinue his fasting, although this is usually not related to the fasting, but is related to the type of food that people consume during Ramadan. Again, how often you would monitor your patients? I mean, would you do a test every week or twice a week or whatever? It's again, there is no consensus. Differs from a person to person and maybe from a physician to physician. Usually, I would do after 5 to 7 days a test from starting of fasting. If things are stable, I would do the next test after 10 days. If things are stable, I would do the third test after finishing fasting of Ramadan. And then I would give the patient another month to repeat the test to see whether we are back to the baseline or if we have increased a little bit or we are progressing or regressing or whatever. So it differs from a situation to the other. Definitely, changes in the body weight is another issue. If the patient had any, and this is very clear in cases of diabetes, as probably we will hear in the next lecture. It's very obvious that you usually would tell your patient, if you feel dizzy or blurring of vision of any manifestation of hypoglycemia, if you measured your blood sugar and you found it's low even before Al-Maghrib by 10 minutes, just break your fast. And do that to avoid that you would not fast for the rest of Ramadan. If you break your fast for 1 day, you might have good fasting for the rest of the Ramadan. We don't have that clear cut limit during fasting in for our CKD patient, but still you have to tell the patient that he should monitor the grave or adverse events that you tell any CKD patient with. Definitely oliguria, edema, breathlessness, tremors, or any abnormal clinical finding. Go ahead and don't be stubborn. Do the test and seek medical advice and break your fast. The diet we've mentioned, we have a lot of problems in Ramadan habits or dietary habits. High potassium for the dried fruits and the khushaf and the tamr, and high sweets and sugary fluids, and all these can be a lot of troubles to the patient, and definitely as well eating very heavy meals over short times. All these should be avoided, and having enough volume of fluids according to the patient situation between iftar and suhoor, another issue. For kidney transplant patient, it is somehow more clear, and we don't allow kidney transplant patient to fast in the first year, and we don't allow them to fast if they have unstable graft function, and we have to be sure that we can manage their immunosuppressive protocol in a way that keep them on the right track. And this nice paper by the Royal College of Physicians have given a very nice summary to who is at very high risk and must not fast, of those with organ transplant and those with high risk and those with moderate low risk that can follow medical advice, and they can fast as well. To cut a long story short, any patient who is transplanted a year or more and he has a stable kidney function for the last 3 to 6 months, no active rejection or even subclinical rejection as suspected by whatever, PRA high or a protocol biopsy or whatever, and on a stable level, trough level, or C2 of the drugs that he is taking as an immunosuppressive protocol with more or less stable doses, not frequently changing doses for the last 3 months, can fast, and definitely without a comorbid condition. And this would need a very specific tailoring and manipulation of the drugs. And we're going to pass through this by the end of the lecture, but I would like to mention an example that people usually are messed with. For those who are transplanted and maintained on the classical triple immunosuppressive protocol using Prograf, Cellcept, and steroids. For the usual, patient would take 1.5 grams of MMF and whatever dose of Prograf. On the usual, they are on 2+2 or 3+3 mg of Prograf per day. So how to manage this during fasting? Knowing that the proper advice is to separate MMF from tacrolimus at least by 1 hour and maybe 2 hours, but 1 hour is okay during their administration to avoid some pharmacodynamic interaction. So what to do in this situation? We would advise the patient to take the Prograf immediately with the Maghrib Adhan. So he would take 2 tablets, 3 tablets, whatever his dose is, and the second dose immediately before Fajr Adhan. So you would give the maximum time nearest to the 12 hours, like 13 hours and 11 hours, that's okay. If the Ramadan is longer than this, like the fasting is 16 hours, for example, or 14, 15 hours, and the night time is 9 to 10 hours, so you can give him like 3 tablets. If he's taking 3+2, give the 3 at the Fajr, so it covers the 15 hours, and the 2 at the Maghrib, so it covers the 10 hours. Then what to do for the MMF? You would give only 500 mg of the MMF 1 hour after iftar, so that you would space it from the Prograf by an hour. For example, you take the Prograf at 6, take the MMF at 7, but only 1 tablet. Then the Fajr would be at 5, and you're going to take the Prograf at 5. Take the 1 gram of Prograf at 4. So you have it from 7 to 4, 500 milligram, and from 4 to 7, the longest duration, 1 gram of MMF. And this is a convenient way to tell the patient how to deal with the medication. And this will come later, but just to mention this. And this is the decision-making algorithm for patients who intend to fast with a solid organ transplant according to their wish and according to the risk stratification. And you will again explore the alternative option, whether a fasting during the winter or giving the fidya. If they are low or moderate risk, allow them to fast, and you have to optimize, educate, and do your emergency plan and monitor the graft function and the trough level and everything. But take care if you're going to monitor trough level for uneven doses, this might be misleading. So in this situation, you might monitor the Cmax better than the trough level. And this is the same that we've mentioned earlier. Then moving to the dialysis patient, and this is a much easier situation. With the dialysis patient, we have 2 issues. First issue is it allowable to fast from the fiqh point of view, during dialysis session, there is a controversy about this between scholars, both the recent scholars and the old scholars. And you can tell the patient both opinions are well appreciated. You cannot, this هذا من يعني ما يقال عنه في مسائل الفقه خلاف لا ينكر فيه. يعني لا ينكر أحد الأطراف على الطرف الآخر لأنه both opinions are respected and they have strong evidence for the both opinion. So you would take whatever you think that it is more optimum and you are convinced with. So you can tell the patient, yes, dialysis does not break your fast because it is not something that enters your mouth. So you're not going to swallow anything, and you're not doing so for manipulation of hunger or thirst or whatever. So you can still fast on the dialysis day. This is from the fiqh point of view. How about from the medical point of view? Definitely, those patients on dialysis are frail patients, and they among those who have a very strong permission not to fast. But again, if they insist, there's not a big deal. You after all, you're not afraid that they would lose further kidney function unless they are on incremental hemodialysis and having good residual renal function. Those patients would be treated like the stage 5 non-D, and you would advise them strongly against fasting. You would tell them and those people are usually obedient and they will hear for your voice. You would tell them you are now dialyzing once a week or once every 10 days or once every 5 days. If you fasted, you'll come out of Ramadan by regular dialysis, twice a week or thrice a week. And this is your choice. If you did not fast, you keep on, and you can fast intermittently during the whole year when the daytime is short to compensate for this. So this is the best advice for those with incremental hemodialysis. For those with regular hemodialysis, there is no harmful effect usually, whether on the dialysis day or not, because on the dialysis day, as we know, as we've heard from Professor Saeed Khamis in his very elegant lecture, Fatigue During Dialysis, that this is one of the dialysis adequacy. So it happens, and people come out of the dialysis session fatigued. So it is advisable to avoid fasting on the dialysis session, not because it breaks their fast, but because they would be very much fatigued, unless they can do it after Maghrib. And these are the iftar tips for those patients during how to eat properly. So it's not only about the fast, but it's also about the eating during Ramadan. And we all know hadith النبي صلى الله عليه وسلم عن المقدام ابن معدي كرب حديث المشهور ما ملأ ابن آدم وعاء شرا من بطنه بحسب ابن آدم لقيمات يقمن صلبه فإن كان لا محالة فاعل فثلث لطعامه وثلث لشرابه وثلث لنفسه. So we should respect this triaging of the abdominal capacity, and we now know and understand the abdominal hypertension and the compartmental syndrome that decreases the renal blood flow and decreases the organ flow, blood flow generally. And this, although we measure this usually by the ascites and the abdominal distension by tumors and so on and so forth, but it can be done. We can do it to ourselves by overeating or over drinking. So we have to be very careful with the drinking. We have to be very careful with the eating. We have to take care of the sweets and the gelatin and the honey and the pudding. We have to avoid the food scents and food visuals, especially during the time of fasting, because you would stimulate to the maximum your satiety, so your hunger center, not satiety center, and this would, you would eat unconsciously. And that's why the sunnah is to eat, to break your fast upon rutab. And even if you look for that, during breaking fast, it is rutab, because rutab are readily absorbed, even more rapid than tamr, because they are more soft and they will be absorbed, and the glucose will be absorbed even from the saliva, to give you a little bit of satiety before you start your food. Whereas during suhoor, the sunnah is tamr, not rutab. نعم سحور المؤمن التمر. The sunnah is tamr, because the tamr, being a little bit hard, it would stay for a longer time during the time of the daytime. Again, during suhoor, you have to make it late, just before Fajr. وما زالت أمتي بخير ما عجلوا الفطر وأخروا السحور, as the hadith of the Prophet ﷺ said. So it's not allowed to have the suhoor at 12 midnight and then start your fasting. This is not proper. You have to make the suhoor just before Fajr. And this is the decision making for PD patient. And this PD patient, maybe because of the fluid intra-abdominal during the daytime, and because of the glucose, which might cause some hyperglycemia that might be not suitable during the daytime. That's why they use the CCPD during time, or they have an icodextrin dwell during the daytime instead of the glucose-based dwell. Unfortunately, we don't have PD in Egypt till the moment on a wide scale. Hopefully that it will be endorsed soon. Systemic lupus, unfortunately, there is no criteria for lupus nephritis, so they will be managed like those patients with CKD according to those situation, and not only lupus, but again for all those people with GN, with glomerulonephritis. Polycystic kidney disease is a specific situation. Why so? Because polycystic kidney disease can get benefits from fasting according to some experimental trial and even some clinical trials that used intermittent fasting by up to 16 hours to enhance a stage of autophagy and to enhance the decrease in cyst growth rate. And these have been shown by a couple of studies that it decreases the kidney volume and preserves the kidney function. Thus, in this situation, it might be helpful to have fasting for those patients. This is our own experience, which is not published yet. We are now in the phase of statistical analysis of the study. Those are patients who fasted during the last year. They were 160 patients. 103 of them, they continued their fast with no significant deterioration in the eGFR, while 57 patients stopped fasting because deterioration of the GFR. 54 of them just returned to the baseline after stopping fasting. Usually this was after 3 to 5 days or 7 days on the maximum from starting of Ramadan. Only 3 patients continued to progress after stopping fasting, and definitely you cannot blame fasting for 3 out of 160 that it was the cause of progression. But we are awaiting for the final statistical analysis to have more insight from this data. Lastly, and I'm not going to go through this thoroughly, but I'm going to leave you with the Arabic version that would have been gathered and made easier by our colleague in clinical pharmacy, Dr. Rami Al-Waraqi. And we'd like to distribute to every patient to help him in his medication with fasting. Definitely, we have a lot of drugs. We've spoken earlier about the management of immunosuppression, especially with the combination of Prograf and Myfortic. By the way, Neural and Cellcept or Neural and Myfortic can be given together. There's no need to separate them apart like others. Anti-diabetic, definitely we're going to hear about this in the next lecture, so I'm not going to mention. Anti-hypertensive, you can continue them, but take care from diuresis. We prefer not to use them during Ramadan, and if you have to, do it at iftar, not at suhoor, and take care of the ACE inhibitor as well, to be avoided, to be taken with a time of low blood pressure or low circulation and low flow. And antiplatelet, anticoagulant, warfarin, aspirin, and clopidogrel can be given, but you need to give them on an empty stomach. So you have to, especially for the warfarin, so you have to choose the time and keep it throughout the month at the same time. And this is the Arabic version of what you do with anti-diabetic, with antihypertensive, with those antiplatelet and anticoagulant, with the anti-dyslipidemic, with the immunosuppression and other types, is written in a good way for our patient to understand how to do and what to do with all these types of drugs. And finally, I would thank you for having me tonight, and I'm open for any question if you wish to start now or to postpone after the next lecture. Thank you.
Thank you, Professor Ahmed, for your very elegant and informative lecture. Jazakallah khair. We'll postpone the discussion after the next lecture, and we'll take the comment of Professor Ayman Rifai before we go to the lecture of diabetes. But before, I want to tell you about two things that I had the pleasure to share in a working group from different Arabic countries and established and risk score for diabetes, so for chronic kidney disease and kidney disease in general during fasting Ramadan, including dividing them into low, medium, and high risks according to risk score. And this will be published within the coming days, and I will supply you, hope to be before Ramadan, to supply you with this. The second is that in CME chapter, we will fast about our scientific activities in Ramadan. إن شاء الله في رمضان احنا هنتوقف. شهر رمضان is the only month in year, and we have كل الشهور بعد كده، فهنسيب لحضراتكم فرصة إنكم يعني تقضوا الشهر من غير ما تكون في حاجة مضطرين تلحقوها، وإن شاء الله دعواتكم لينا إن احنا نقدر نستأنف بعد كده بعد السكيدول بتاعنا as it is. Please, Professor أيمن رفاعي, unmute yourself. اتفضل دكتور أيمن. unmute yourself, دكتور أيمن. دكتور أيمن.
Well, thank you very much, Professor Ahmed. Thank you very much, Professor Ahmed. First of all, I have to admit that I really enjoyed your comprehensive and very informative presentation, covering nearly all the categories of renal patients. And actually, I like the smart and gentle and civilized approach to deliver the message and the advice to those who insist to fast, especially our dear elderly and senior patients. What I like also to emphasize that this advice at the end of the day is not a dogma according to numbers or according to the CKD stages. But I think the decision all the time should be tailored for each patient according to several factors. And I think the most important of them are the comorbidities and the polypharmacy they need accordingly. Just a comment for the tacrolimus administration in transplant patient during Ramadan. The second dose, which should be, as you mentioned, immediately before Fajr, and as you know, it's better to be on empty stomach or 2 hours after meal. So I think it's better to have the suhoor 2 hours earlier before Fajr, not immediately before Fajr. And for the level, as you mentioned, it will not be consistent and reliable during Ramadan. So I think it's better to skip doing the level during Ramadan, especially those patients who are allowed to fast are usually not recent transplant, and usually they have the liver every 2 to 3 months. So I think it's not advised to have or to estimate or to do the level of CNI during Ramadan. Thank you.
Thank you, Professor Ayman. You, Dr. Ahmed, we have many questions on the chat and many comments, so please stay with us, and we are appreciating this for you. And the next speaker will be Professor Hosam Ghazi, Associate Professor of Internal Medicine and Nephrology in Mansoura University. Will speak about diabetes and Ramadan and how to deal with our diabetic patient in Ramadan regarding fasting advices and dealing with diabetic medication. Please start to Dr. Hosam. تفضل.
To join such a prestigious event. Also, I'm happy that Professor Inas Shaltut is chairing this session, and with my professor, Dr. Ayman Rafai from Mansoura University. Today, I would like to talk about the diabetes and Ramadan and how to prepare your patient. Unfortunately, this lecture is late sometimes, but we wish in the next year, inshallah, we can make it in the earlier weeks before Ramadan. In my agenda today, I will talk about some introduction about the changes which is happening in Ramadan and why diabetic patients are risky to fast of Ramadan. Not all of them, but some of them are risky to fast Ramadan. Then what are the pre-Ramadan assessment we should do to our patient? And not all the patients with diabetes are at the same risk to fast Ramadan. There is some risk categorization for patients with diabetes. And actually, I'm happy because we have a well-established consensus. One of them are Dr. Inas Shaltut that mentioned. We have, as a diabetologist, we have a well-established consensus and we have a lot of studies. So somewhat we are lucky than nephrologists that you have still till now. You don't have a lot of studies about this, but we have a good studies about patients with diabetes. Then I will give you some commonly asked questions from the patients and from the healthcare providers, and what to do with the oral anti-diabetic drugs and what to do with the insulin dose. Then we'll take the home message. Like most of Muslims, majority of patients with diabetes, regarding they are type 1 or type 2, regarding they are complicated or not, majority of them, when they are asked and questionnaire, majority of them wants to fast. And actually, we are afraid to allow all patients with diabetes to fast because there is a risk of fasting are present. The first one, which is the dehydration, especially in the hot countries, especially in the outdoor workers, especially if the patients are not well controlled, especially if they are taking diuretics or SGLT2 inhibitors. With dehydration and hyperglycemia, we are afraid to develop thrombosis. And there is a lot of studies that mention that the patient with uncontrolled diabetes, more than 50% of them may develop central retinal artery thrombosis if they are uncontrolled. And a lot of them also may develop macrovascular complication. But the most studied and the most problematic thrombosis that happen is with the retinal arteries. And this is our major problem. Also, if the patient is taking insulin or taking sulfonylurea, we are afraid from the hypoglycemia. Unfortunately, majority of patients not follow the sunnah and not follow the should be diet regimen. And a majority of patients, unfortunately, with the bad habits, especially here in Egypt, are getting weight after Ramadan. So all of this are hazards of fasting or risk of fasting to the patient with diabetes. As I told you, fortunately, we have a good guidelines about this. My lecture is mostly from the DAR guidelines, Diabetes and Ramadan guidelines. Professor Nas Sheltut is one of the authors of this consensus. So it is easy for me to go with this. Unfortunately, the studies that dependent in the DAR guidelines, not randomized control trials. And we have a small number of patients, and especially we have recent drugs like SGLT2 and GLB. We have studies about this, but the older drugs, like the biglitazone, like the sulfonylurea, not have a large mega trials about this, and most of them we depend on our experience with making patient fasting with this. Also, the patient with diabetes is not fasting only Ramadan. We are fasting only that ayam al-Qamariya, 13, 14, and 15. We're fasting the first 10 days or 9 days from Dhul Hijjah. So we have these rules could be applied to any time of fasting all over the year. We have a lot, alhamdulillah, we have a lot of number of Muslims, and the number of Muslims are increasing. In the Middle East, we have about 20% of the Muslims worldwide are present in the Middle East, our community. And we have 3 mega trials. The first one was in 2001, EBDR trial, then the DAR-MENA trial with type 1 diabetes, then the DAR globally survey trial in 2020. We have a lot of trials. This is a mega trials developed in more than 10 countries, carries more than 1,000 patients. So we have a good experience and we have a good studies about diabetes and Ramadan. The first thing is, what are the changes that happen to patient with diabetes if he is allowed to fast Ramadan? Normally, we have 3 main meals, the breakfast and the lunch and the dinner, and we have some midday snacks and the late night snacks. The Ramadan fasting is different from the other religions fasting or the prolonged starvation. If the patient is having prolonged starvation, so he is most of the day is not taking any calories. But Muslim fasting or Ramadan fasting, about half of the day or 60% of the day is not taking calories. Then we have a high amount of calories in the remaining part from the iftar to the suhoor. So this is the first change of the dietary habit during Ramadan. Number 2, also the activity itself and the sleep itself is changing. Normally, we are sleep at 10, 11, 12 p.m. Then we are awakened at 9, 8, 11 a.m. Then we have 3 main meals. But this is changing. The diet habit and the sleeping hours are changing in Ramadan. So this is also affect the circadian rhythm of the hormone, affect the pharmacokinetics and pharmacodynamics of the drug, affect the caloric intake, affect the hormones and the dehydration. So all of this are challenges making the patient with diabetes fasting Ramadan at risk. Also, there is a change in the homeostasis of the fluid balance in the patient with Ramadan. With fasting, with liberation of the urine and insensible water loss, at the end of fasting hours, the patient is losing some weight and the patient osmolarity is increased. The patient is dehydrated. If he is not well controlled or hyperglycemic, so he is at a high risk for thrombosis. So خليني أسبق الأحداث زي ما بيقولوا, we always told the patient that if your blood glucose is less than 70, you should break your fast. And this is logic. And no one of patients asking me why. Because I'm developing hypoglycemia, and this is logic. And also we announced for the patient that if your blood glucose is more than 300, you should also break the fast. And most of patients are telling me, why? My blood glucose is high. Why should I break the fast? For these reasons, because your blood viscosity is increased and you are at a high risk to develop thrombosis. You need urgently to take a lot of fluids and to take correction medication to resolve the dehydration and hyperglycemia in a way to avoid the hypercoagulable or thrombotic state. Normally, if the patient is not diabetic, normal persons with a normal glucose homeostasis, if you are taking glucose from the food, the insulin is stimulated from the beta cell, the glucagon is inhibited from the alpha cell, so the liver is taking this glucose, and the glucose is entered to the liver and muscle, and all of this are decreasing the blood glucose in a postprandial manner. If you are in a fasting state, there is no carb is coming from the diet, so the insulin secretion is decreased from the beta cells. In controversy, the glucagon hormone is increased from the alpha cells, so this will lead to stimulate the liver and the muscles try to avoid the uptake of the glucose from the blood. Also, it helped to make glycogenolysis and gluconeogenesis, trying to avoid the hypoglycemia. If the patient is having absolute insulin deficiency, we mean type 1 diabetes, or relative insulin deficiency, those are affected. And we are afraid in the fasting state that if you don't have enough insulin and you have a lot of glucagon, this may lead to ketosis because the glucose metabolism are not well going in the normal hormonal balance. So we are afraid also from the patient with type 1 diabetes or severe insulin deficiency or advanced type 2 diabetes to get ketosis and to develop diabetic ketoacidosis. Are all the patients with diabetes are the same risk of fasting? The answer is no. There is three main factors that influence the development of complications or risk during fasting Ramadan. The first thing is related to Ramadan itself. The same patient, for example, when he is going to Egypt, may be at risk that if he is going to another country, if he is allowed to fast. The length of the fasting hours, are you fasting in a hot or cold climate? The season of fasting, is it summer or winter? The geographic location, the social changes and social habits, past experience, all of this are related to Ramadan itself. It is not related to the patient. And most of this are non-modifiable. Also, the diabetes-related factors. I'm dealing with a patient with a recent type 2 diabetes. He's having a good insulin reserve or advanced type 2 diabetes with severe insulin deficiency or and basal bolus regimen, or patient with type 1 diabetes. The same is also. I'm dealing with patient without complication, differ than the patient with nephropathy or macrovascular complication. What is the anti-diabetic medications that the patient is taking? Is he taking drugs that not form severe hypoglycemia, like SGLT2, DPP4, GLP, metformin, pioglitazone, or if he is taking drugs that may lead to severe hypoglycemia, like glibenclamide or basal bolus regimen? The patient is aware and have a good alarming signs before developing of hypoglycemia, or the patient is having autonomic neuropathy and is having hypoglycemic unawareness. All of this factors are important. Also, is the patient have a good connection with his physician or his diabetic educator, that if any complication developed during the fasting could be telephoned or reach him, whatever the method, and he have a good access to the healthcare provider, or he is away from the healthcare provider and do not have any access for them. All of this are changing the risk. Also, the factors in the patient himself, the age, the occupation, the gender, is it pregnant, lactating, the type of the meal pattern itself, the job, the exercise pattern, the motivation to do self-monitoring blood glucose or to monitor his carb or to monitor his diet or to monitor his exercise or not, the personal preference himself. We have a lot of patients that once we all told him, you are not allowed to fast, he is crying and doing a lot of problem, and he is thinking that his Islam is lost and he is get out from Islam just when he is not allowed to fast. And other persons, when we are telling him, you may have the chance or the rukhsa to not to fast, is telling me, okay, from the first time, I don't feel any problem. So this is all of this are factors with dealing with a patient, not making all the patient with diabetes at the same risk. This is the most important slide in my presentation. And if you are not familiar with it, you should print it out and put it under your glass of their office and to see your patient. Here is a simple scoring system that any one of us if see the same patient, we will reach the same scoring system. So we are all of us deciding, is our patient are low risk to fast, or moderate risk to fast, or intermediate, or high risk to fast. I want to go for this. If the patient is scoring from 0 to 3, his light is green, so he can fast safely, and it is haram if you not fast. It is, you are not allowed to be not fasting. You should fast, you can fast safely. If the score is high, more than 6, and remember this number, 3 and 6, more than 6, it is high risk. And if you are insist to fast, your fasting is haram, because the hazards from fasting is more than the benefits. Those with yellow color, the moderate risk from 3.5 to 6, they may allow to fast, they may not allow to fast. They have to choose. But if they are allowed to fast, they should monitor their blood glucose, they should monitor their carb, they should know when to break their fast, when to continue their fast, and so on. So remember number 3, 0 to 3, it is low risk, you can fast safely. Remember number 6, because we will need it in the next slide. Remember number 6, if it is just you collect 6, you should not allow to fast. Between 3.5 to 6, it is dependable to and your patient with the discussion. Okay, number 1 from this questionnaire is the type of diabetes. The type 1 diabetes is taking 1 score, and type 2 is 0. The duration of diabetes, if it is 10 years or more, it is more risky to fast, so it takes 1. If it is less than 10 years, it is usually less complicated, so it is less risky, so it is 0. Regarding the hypoglycemia, there is, I told you, remember number 6. If you have hypoglycemic unawareness, from this point only, you take 6.5. So if the patient is having hypoglycemic unawareness, what you should not continue the questionnaire or the scoring system, he is not allowed to fast. If the patient is having recent severe hypoglycemia that the patient could not take the glucose by himself, he needs external assessment. The patient is going to neuroglycopenic manifestations and coma, and he needs external assessment to help him. If the patient is having those severe hypoglycemia, 5.5. If the patient is having multiple weekly hypoglycemia, 3.5. If the hypoglycemia is less than 1 time per week, every 2-3 weeks, for example, it is 1. If the patient is not developing hypoglycemia, it is 0. What about the previous control of the patient? If the patient is entering Ramadan with an A1C more than 9, it is risky to develop complications during Ramadan, especially the macrovascular complications and the thrombotic event. So he's taking score 2. If he is between 7.5 to 9, taking 1. If he is less than 7.1, he is taking 0. What about the type of the drugs? If he's taking if he's taking multiple daily injections, basal bolus or basal plus 2, he's taking 3. If he's on basal bolus or insulin pump, 2.5. If he is once mixed pre-mixed insulin like the aspart and degludec, is taking 2. Basal insulin only is 1.5. Glibenclamide, which is the old generation sulfonylurea, is taking 1. The recent sulfonylurea like gliclazide MR or glimepiride or ribaglinide, short-acting secretagogues, are taking 0. The others oral, which is not familiar to cause hypoglycemia, severe hypoglycemia, so is taking 0. If the patient is having SMBG, the blood glucose monitoring system, the home monitoring system, if it is indicated and the patient could not do it and not conducted, he is taking 2. A lot of our patients, unfortunately, with type 1 or type 2 and basal bolus or pre-mixed insulin, is not having a home monitoring blood glucose, and he is having symptoms, or we don't have any registers for him, so this is risky, so he's taking 2. If it is not optimally conducted by the patient, taking 1. If it is conducted once indicated, he's taking 0. If the patient is having diabetic ketoacidosis or a hyperosmolar non-ketotic coma in the last 3 months, he's taking 3. In the last 6 months, he's taking 2. In the last year, he's taking 1. If he is not developing, he's taking 0. If the patient is having unstable macrovascular complications, always unstable angina or recurrent transischemic attack or recurrent intermittent claudications or recurrent vegetations or. So it is 6.5. So it is out from the outside, not allowed to fast. If he's having a stable macrovascular complication, he's having a cardiac stent or cerebral stent or past history of cerebral stroke or past history of peripheral arterial disease more than 1 year, and he is stable and everything is okay with a follow-up, taking 2. If he is not having known established macrovascular complications, is taking 0. This is your point of interest. If the patient is GFR less than 30, 6.5, this is from the beginning, not allowed to fast. From 30 to 45 is taking 4. From 45 to 60 is taking 2. If he is more than 60, he is safe, so it's 0. If the patient is pregnant and not the target, 6.5, not allowed to fast. And usually in our experience, we don't feel difficulty to convince the patient pregnant to not to fast, because usually we say that it is the normal pregnant woman or lactating woman is having the rukhsa not to fast Ramadan. So if you are diabetic, better not to fast. You are diabetic and not controlled or in basal bolus or in type 1, it is haram to fast. So it is, you should not fast. If the patient is frail or having cognitive impairment from the beginning, not allowed to fast, 6.5. He is more than 70 and he is home alone and he is having not support, no good caregivers, he takes 3.5. If everything is okay, not frail and no problem with cognitive function, he is taking 0. The physical exercise, if the patient is high intense physical exercise, he is taking 4. If he is moderate intense, 2. If he is not intense, is 0. Past Ramadan history, if he is a bad past Ramadan history or negative experience of hypoglycemia, thrombosis, diabetic ketoacidosis, whatever, any problem, taking 1. If he has no bad experience or good experience, he's taking 0. If the fasting hour is more than 16, taking 1. If it is less than 16, taking 0. So this is the most important slide in my lecture. You should print it. It is freely published on the internet. You can get it, and you should print it, or you make it in your mobile to decide is your patient is allowed to fast or not. As I told you, if he is scored from 0 to 3, he can fast safely and haram not to fast. If he is scored more than 6, he should not fast and haram. If he is fasting, between them, you should discuss with the patient. And all of this, fortunately, with Dr. Magdi Ashur, he is famous, one of Azhar's professors. We have a documented fatwa from Dar al-Ifta that all of this, we said it is documented in Arabic. And for me, myself, I have a hard copy with this and print it and give it for the patient to make him not feel يعني ما يفتكرش ان ده كلام دكاتره وخلاص يعرف ان ده كلام جاي من الازهر. If the patient does know that this is an Azhar ifta, he is feeling comfortable a lot of time. So what to do before Ramadan? As I told you in the beginning, unfortunately this lecture is late. We should start our journey of preparing our patient 6 to 8 weeks before Ramadan. We should classify him about the risk of fasting, and we should make with him know when and what is the rule and the importance of self-monitoring of the blood glucose. We should make with him a clear numbers when to break the fast, when to do exercise. And by the way, Taraweeh is a good exercise, and we advise him to make and to pray Taraweeh because it is a good exercise. We should put for him a good fluid and meal planning, and we should tell him to do what to do with his medication. We take history and everything, as I said before. Why we are saying 6 to 8 hours weeks before Ramadan? Because I will say now that there is some drugs like the TZDs, pioglitazone, or the GLB. To reach the maximum effect, we need 2 to 4 weeks at least. So we should start early. Also, we always allow our patients to try to fast in Sha'ban or Rajab, because if there is any bad experience, we can correct it. And if the patient is break his fast in Sha'ban or Rajab, is not so sad. But if he's break his fast in Ramadan, at the first experience with fasting in Ramadan, and he's breaking his fast, especially the first 2 or 3 days, this may give the patient bad experience and may affect the quality of life and affect his mood during the remaining days of the month. This is also the second important slide in my lecture. I always write it in my prescriptions to my patient in a red color and highlight it, number 70 and number 300. If your blood glucose is less than 70 at any time, even 10 minutes before iftar, you should break your fast. If your blood glucose is more than 300, as I told you, from afraid to develop hypercoagulable state, you should break your fast and take a lot of fluid and take extra medications. If you are, for example, driving or at your work or traveling and you don't have your blood glucose monitoring apparatus, and you develop the classic symptoms of hypoglycemia, or you develop a sudden or acute onset illness, for example, severe gastroenteritis or severe influenza, you should allow to fast to break your fast, even if you don't have documented numbers away from the 70 and the 300. The last part, or before the last part of my lecture, what's the commonly asked question from our patient? Number one, you told me that it is important to monitor the blood glucose. When should I monitor the blood glucose? Is it every 1 hour? Is it once? Is it when should I do monitoring for my blood glucose? The ideal is the 7 points guidance for the Ramadan, 7 points measurement. Usually I make the patient it with الصلاة. يعني دايما اقول للعيان قيس السكر مع اوقات الصلوات المعروفة. The first one is at the suhoor or before suhoor meal. And this is usually will give him an idea, especially if he is taking insulin, about if he need extra correction doses of insulin or his short-acting sulfonylurea, for example, or not. And if the pre-suhoor is high, usually he should monitor strictly the first 2 or 4 hours after Fajr to avoidance of hyperglycemia and to break his fast from the beginning of the day. Also in the morning, usually I say the patient, when you, after Salat al-Duha, you take also some reading of the blood glucose. In the midday, I say with the patient after Salat al-Duha, take another blood glucose monitoring. Mid-afternoon, after Salat al-Asr, you take another reading. The most risky hour in the fasting of our patient is the last hour before Maghrib, because this is the peak of development of hypoglycemia or the peak of development of hyperglycemia, because your medications is ending and the hepatic glucose production at the maximum. So we are afraid from the hyperglycemia. So this is the most important hour in the day of fasting. Also, we should monitor 2 hours after iftar. Once you come from the Taraweeh, 2 hours after iftar, you should monitor to correct the carb in your iftar meal, to correct the insulin dose in your iftar meal. This is an important any time at the day. If you feel hypoglycemia or hyperglycemic classic symptoms, or you feel unwell, you should monitor your blood glucose. Those points, 7 points, especially in the first 2 or 3 days of Ramadan, if everything is going okay, you can just concentrate on the after suhoor and the al-Dhuhr or al-Asr, and before Maghrib and after 2 hours after Maghrib. So this is the most important 4 points in the day. What is the general rule? I'm not a dietitian, and this is the general rule to be applied for majority of the patients. Number one, we should have a well-balanced meal. 50% from the complex carbohydrate, 30% from the protein, and less than 35% is from the polyunsaturated fatty acids. Also, we prefer the low glycemic index and high fibers foods, not, for example, the bread from the high fibers than the white fibers. العيش البلدي مش العيش الفينو، دايما بنصح المريض. You take the vegetables or the fruit, is it same? Better than to take it as a juice. You can add some fats to your meal. All of this are lowering the glycemic index and preventing the postprandial glucose excursion, especially at the time of iftar. Also, we usually advise our patient to minimize the high saturated fat and to minimize the sugary desserts, and to use a small amount of oil, especially the olive oil or canola oil. And always every 1 hour you should drink water to avoid the dehydration during the fasting hours, and to avoid a lot of caffeinated and sweetened drinks, especially at the suhoor meal, because it has a diuretic effect. As all of us know, the symptoms of hypoglycemia and hyperglycemia, again and again and again, if the blood glucose is less than 70, more than 300, you should break the fast, or at any time, even without monitoring. If you have the classic symptoms of hypoglycemia or classic symptoms of severe hyperglycemia or acute illness developed, you should break your fast. What is the calories allowed to me, doctor? If you are dealing with a female, short female, less than 150 centimeter, and you allowed or you want to reduce her weight after Ramadan, so you advise her to take 1,200 kcal per day. If you are dealing with a short woman and you want to keep her weight before Ramadan like after Ramadan, or if you are dealing with a long woman, more than 150 centimeter, and you want to make her lose some weight after Ramadan, you advise her to take 1,500 kcal. If you are dealing with a tall woman or a man and you want to make him reduce his weight after Ramadan, or a tall woman that she maintain her weight after Ramadan, so you advise him to take 1,800 kcal per day. If you are dealing with a man or woman who not want to lose her weight, you are allowed to take 2,000 kcal per day. A lot of patients is talking with you about, I cannot estimate my calories, or please give me simplified way. This is excellent photo is attached in the guidelines, that in a simple way, imagine that this is your dish divided into 4 parts. The one quadrant is for vegetables, 1 quadrant for protein, 1 quadrant for lentils or soups or beans, and 1 quadrant for the rice or pasta. And don't forget 2 glasses of water. If you'd like to add oil, it's better to add good oils like the olive oil or canola oil, 2 teaspoons of oils. And if you want to take vegetables, maybe in the size hand of fruit, and the size of closed hand fist, you can take it. And this is the simplified way that give the patient is about 500 kcal per day, per meal, I'm sorry. Okay, the final part of my lecture is how to modify your patient drugs. Number 1, metformin. Metformin is easy because usually we don't have the 3 days, the 3 doses the 3 times doses per day. Usually we take the patient with metformin XR, or the patient is taking the IR. Usually the dose is the same because we are not afraid of severe hypoglycemia from the metformin, but usually if the patient is taking the XR, for example, 2 grams per day, usually we advise him to take the 2 grams at iftar time. If he's taking 1 gram IR for example, in the morning and in the evening, we advise him in Ramadan to take it in the iftar and in the suhoor. If he's taking, for example, 500 milligram of metformin with each meal 3 times, he can take 1,000 milligram at the iftar and 500 milligram at the suhoor. So the metformin is not changing the dose. We do not reduce the dose because we are not afraid from hypoglycemia, and it is the majority of the dose, or most of the doses are taken with iftar. We are afraid from the sulfonylurea because especially the old generation sulfonylurea like glibenclamide or glyburide are risky to develop hypoglycemia. And if the patient is elderly, he's better not to take sulfonylurea during Ramadan. It's better to shift him, for example, to DB before metformin. Then after Ramadan, if he cannot afford the DB before metformin, after Ramadan he can come to sulfonylurea. If you have no money or everything is okay and he is controlled, better to shift him to the recent sulfonylurea like the gliclazide MR or the glimepiride. If the patient is well controlled and not having any hypoglycemia before Ramadan, so he can continue with sulfonylurea. And there is a lot of studies, especially on gliclazide MR, a lot of studies that report that the hypoglycemia, severe hypoglycemia, is comparable with DPP-4 inhibitors regarding fasting Ramadan if the patient is well selected and well controlled before Ramadan. So if he's taking, for example, gliclazide 60 or glimepiride 4 milligram, he takes the same dose at the iftar time. If he is developing some sort of recurrent hypoglycemia before Ramadan, you can reduce the dose. For example, if it is gliclazide 60, make it 30. If it is glimepiride 4, make it glimepiride 3. If he is developing hypoglycemia before Ramadan, because surely he will develop hypoglycemia during Ramadan fasting. TZDs is very good. He can continue the same dose before Ramadan and take it at the iftar. But please, those times we have less than 2 weeks before Ramadan, those times better not to start with your patient TZDs, because pioglitazone and TZDs to reach the maximum effect need 2 to 4 weeks. So usually, if you are especially enclosing in your patient's sulfonylurea, usually you are afraid that the maximum effect of those drugs will be in Ramadan. So you are afraid from developing of hypoglycemia. But if the patient is well controlled on TZDs, you can keep him without reducing the dose and advise him to take the TZDs dose at iftar. Regarding incretin-based therapy, the DPP-4, it is the excellent, the gold standard drug in Ramadan. It's rapid acting, safe. You are not afraid of severe hypoglycemia. If the patient is well controlled on DPP-4 before Ramadan, you can keep him in the Ramadan the same dose. If he is taking, for example, once daily DPP-4, like linagliptin or sitagliptin or allogliptin, he take this dose at iftar time. If he is taking short-acting DPP-4 like vildagliptin, he take it with iftar and with suhoor. Regarding GLP, it is safe. Keep it like the same dose he is usual dose before Ramadan. You are not afraid of hypoglycemia, but again, the same problem with TZDs, that most of GLP, to reach the maximum effect, you need at least 2 to 4 weeks. For example, if I'm dealing with liraglutide, I usually start 1 week, 0.6 milligram per day, then 1 week, 1.2 milligram per day, then 1.8 milligram per day. So to reach the optimal dose, you need 2 to 3 weeks. The same with semaglutide. 0.25 for 1 month, 0.5 for 1 month, then 1 milligram per 1 month. The same with oral semaglutide, 3 milligram first month, 7 milligram the second month, 14 milligram the third month. So if the patient is controlled before Ramadan, he can keep it and take the dose at any time he wants to take. It is not a matter. But if the patient is taking oral semaglutide, which is the repulses, you should announce in the usual days, and you should insist on this point in Ramadan, that he should take the tablet of semaglutide with a half cup of water, and he should wait at least 30 minutes before starting his meal, because this drug is affected by food intake with the drug. Regarding the SGLT2 inhibitors, it is safe. You can continue at the same dose. And we have, even in Mansoura University and in a lot of countries, it is safe in Ramadan. If the patient is already taking it and controlled and nothing, without any severe complication, usually most of studies found that the hemodynamic states continue safely in Ramadan and after Ramadan. Usually, according to the DAC guidelines, it is better 2 weeks before Ramadan not to prescribe SGLT2 for the patient, because usually in the first few days we have some hemodynamic changes, especially if your patient is not well controlled. But if the patient is already controlled in it, he is not having a past history of aglycemic ketosis, or not risky to develop dehydration, or his GFR is not less than 45, better to keep it the same dose and take it with iftar. If you are prescribing, all of us know now that the dapagliflozin and empagliflozin may be used in a non-diabetic indications, like heart failure with a preserved or reduced ejection fraction, proteinuria, and diabetic kidney disease. So you should start, especially before Ramadan, the lower dose. For example, EMBA 10, not EMBA 25. Canagliflozin 100, not canagliflozin 300. The first, start the lowest dose, then after Ramadan, you may upgrade the higher dose. We always advise the patient to take it with iftar, as I said, and if the patient with diabetes is advised to increase his fluid during iftar hours, The patient with SGLT2, he should advise 10 times to increase his fluid during iftar hours, because this is very important, and to avoid dehydration during fasting hours. If the patient is heart failure with reduced ejection fraction, ischemic cardiomyopathy, advanced chronic kidney disease, you should revise from the beginning. Is the patient is allowed to fast or not? Because if I'm dealing with a patient with advanced heart failure or a patient with advanced chronic kidney disease, stage 4 or 5, as we said, it is better to not to fast, because this is maybe risky, especially with presence of diuretics and SGLT2 inhibitors. As I said, if the patient is controlled on the dose, we are not required to reduce or to stop the drug, because everything, and we have a good evidence in the last few years that the patient can safely fast after with SGLT2 after Ramadan. Last part is the insulin. If the patient is taking once daily pre-mixed insulin, which is the Ryzodig or the combination between aspart and degludec, we can take it with iftar, and you may reduce 10 to 20% according to the patient. If the most of patients in Egypt taking the pre-mixed insulin, the main dose in the morning is taking before iftar, and we reduce the dose of the evening 20 to 50% and take it before suhoor. And all of us know that insulin injection is not break the fast. الحقن الانسولين مش بتفطر. So all of us know that the conventional pre-mixed insulin should be taken 20 to 30 minutes before the meal. So usually if the patient is taking conventional pre-mixed insulin or the human insulin, we advise him to take the insulin 15 to 20 minutes before al-Maghrib, adhan al-Maghrib, to avoid the hyperglycemic excursion and the onset of the insulin is not working. If the patient is taking 3 times pre-mixed insulin, and here I'm talking about the pre-mixed analogs, not the human insulin, because the human insulin is not taking 3 times. I'm talking about the pre-mixed analogs. Usually we take the big dose with iftar, and we take a small dose with suhoor, and we omit the middle dose because we have 2 main meals in Ramadan. Regarding the basal insulin, either if it is basal oral or basal GLP in a fixed ratio combination, or alone, if basal GLP in separate injections, or basal bolus. Regarding the basal insulins, the recent or the new generations like Glargine and 300 or degludec or Glargine 100, it is taken once daily. So it is allowed to take it, or better to take it at iftar time, because the least concentration in the blood will be in the period from al-Asr to al-Maghrib. So this is the least regimen to avoid the hypoglycemia in your patient. If the patient is taking twice daily basal insulin, like the NPH or Detimir or Glargine, the all insulin, he take the usual dose with iftar, and he take 50% less of his evening dose at al-suhoor. But for myself, I usually prefer, even at this month, to shift him to the long-acting basal insulin to avoid the hypoglycemia in this patient. Mr. Chairman, dear colleague, I'm finished my presentation. I just want to take some announcement about some few take-home messages. Ramadan fasting and pre-assessment for Ramadan with patient diabetes is very important and should start more earlier than those times, 6 to 8 weeks before. As I told you, the most important slide in my presentation is the scoring system. It is very important to categorize your patient. He is low risk to fast, or moderate or intermediate risk to fast, or high risk to fast. And health educations and meal planning and when to break the fasting is crucial for every patient, and you should insist for him. Regarding the oral drugs, all of them could be taken by the same doses at al-iftar. If the patient is taking short-acting sulfonylurea, better to develop to take long-acting sulfonylurea at Ramadan. All the other drugs could be taken safely, but bioglitazone and GLP, better not to start it in those days, 2 weeks before Ramadan, because it needs at least 2 to 4 weeks to reach the maximum effect, to avoidance of hypoglycemia to develop in the early Ramadan period. Regarding insulin, if the patient is taking pre-mixed conventional insulin, which is the most important, the same morning dose is taking 15 minutes before al-Maghrib, and 20 to 50% reduction in the evening dose, and it is taking before al-Suhoor. If the patient is taking basal insulin, we advise him to take it at al-iftar and to reduce 15 to 20% of it. If the patient is taking pre-mixed analogs, Rhizodec, which is the Aspart and Diglodec, he can take it safely at iftar time. If the patient is taking 3-brandial insulin, we take the big dose with al-iftar, and we take a smaller dose at al-suhoor, and we omit the afternoon dose regarding Ramadan period. Finally, I would like to thank Dr. Yasser for inviting me to be with you, and sorry to be late. And if you have any questions, I'm ready to discuss with you. Thank you.
Thank you, Professor Hosam, for this extremely comprehensive and interesting lecture. Professor Ines, unmute yourself, please.
Thank you, Professor Hosam. This is a very informative lecture, really excellent. You said all aspects of fasting diabetes with Ramadan. Thank you very much for this lecture. And did you hear my voice?
Yes,
Not
yes.
yet?
Yes.
Okay. I have really some comments on Professor Ahmed lecture. May I or not?
Please, yes, if you please. اتفضلي حضرتك, if you please.
Can you hear me now? Yes?
Yes.
Okay. Professor Ahmed said if the patient is like a very high risk patient to fast, we should help this patient. In my opinion, no, because I shouldn't help the patient to harm himself. This is not expected with our medical practice. If the patient is having very high risk to fast, then we should convince the patient by all means. And if he refuses to take the advice, then we say, no, we cannot help you. It's like if the patient is having some complication will happen without even doing a surgery or so. And if the patient is refusing surgery, then we say, no, we cannot help you because this is not the right medical advice. And usually we go to some sentence said by المجلس الأعلى لعلماء المسلمين. مجلس الأعلى لعلماء المسلمين قال إن كان هناك خطورة في صيام المريض أو من صام وهناك خطورة في صيامه فهو آثم. This is usually very convincing to the patients, and I use it, and sometimes I have the photo and let the patient see them because I cannot help the patient to harm himself. This is my first comment. I can say all the comments rapidly, not to take your time. For pregnant ladies, they should not fast at all. And diabetic pregnant ladies are not allowed to fast at all. فوق كل ذي علم عليم، ربنا أعلم، وربنا أعطى الرخصة للسيدة الحامل إن هي تفطر without even diabetes. The pregnant lady can have hypoglycemia even without using any hypoglycemic medication. And those studies done on pregnant ladies, they didn't study the effect or the long-term effect on babies in the future. For pregnant diabetic lady, for example, we didn't study if this child will have some mental impairment in the future or not. We didn't study because we are not having any long-term studies. Also, we know the effect of hypoglycemia on the adult brain. It can lead to dementia. So what is the effect on the infant? This is another comment. We had also fatwa from Fatwa House for the Arabic Association for the Study of Diabetes and Metabolism. this fatwa, and I can show it to you. It is signed by Dr. Magdi Ashur, the Mufti consultant, and also signed by the Mufti and signed by Dr. Hosam, who is responsible for the written fatwa in Fatwa House. And Dr. Hosam attended many meetings with us. So the Fatwa House says that the medical opinion is the more important opinion in this topic. It is the opinion that we should take for fasting or not to fast, who are exempt for fasting according to the medical opinion, and the Fatwa House will endorse the medical opinion. Another topic, the intermittent fasting. The intermittent fasting is not Ramadan fasting, because the intermittent fasting, we eat all the day while we are working and we are doing effort, and we fast during night when there is no effort and no work. So it's different. It's not Ramadan fasting. And also intermittent fasting allow liberal fluids. It's not like Ramadan fasting. So intermittent fasting is not Ramadan fasting. We had also a study in Qasr al-Aini about the effect of a chronic CKD on the development of cardiovascular complications in the future after Ramadan fasting. So please, we can take a look on this study. These are my comments, and we can discuss, but I think we were going to take too much time. Thank you very much. I have done speaking. Thank you.
Thank you, Professor Ines. We have some questions.
We have many comments. Dr. Yasser, but I have to answer for Professor Ines for some of her comments. Obviously, the message were not clear enough. We are not allowed to leave a patient to harm himself, but we should take his hands. Like if the patient insists to fast, we're not going to tell him, go and die. We're going still to manage him to the best of our knowledge, how we can help him. We are not approving what he's doing, and we have already told him what he should do. But likewise, when we have a patient who refuses dialysis, and it is the right of the patient in all types of medical dusturs around the world, from the previous eras till the current era, that the patient has the right to refuse medication and to refuse treatment. And in spite of this, you have to give him the best care ever. And that's why I gave the example of patients who are refusing dialysis. Still, when a patient refuses dialysis against medical advice, you're not going to tell him, so go and die. You're going to tell him, I'm going to treat you to the maximum that I know, and every time I'm telling you that you are harming yourself. This is the same situation that I mentioned if the patient insisted on fasting against medical advice. So I think this should be clear. The next, no, please don't, no, please, because there's no time. I'll answer the all comments, and then we can.
Dr. Ahmed, will you let him sign a consent that he's harming himself?
No, definitely not, because we never do that.
The patient can go to sue the doctor saying that you harmed me, you killed me.
Okay,
this is not a procedure to sign a consent against. Yeah, Dr. Ines. Okay.
دكتور أظن النقابة مش هتسمح لدكتور إن هو يساعد العيان على أذية نفسه. يعني ده مش medical legal. أنا شايفة إن ده غلط. وبرضو يا ريت نتناقش بعد كده في وقت، طبعا أنا مش عايزة أخد وقته.
نفرض حلقة المناقشة عشان في بس many comments. Chat. Dr. Ahmed, a question to Dr. Ahmed about in plenty water intake, advices of taking much more water. Do you agree with this? You mentioned about other polycystic kidney disease, and what about other diseases such as urinary tract infection, urinary stones, and of course, CKD?
Trials with water intake or fluid intake in general in CKD is still controversial. There have been many trials. The most famous one was sponsored by Danone company, I think. That's why the bias was very high in this trial. And assuming that giving the patient plenty of water is beneficial to the kidney is based on trials of those with autosomal dominant polycystic kidney disease, with those with nephrolithiasis, and with those with repeated UTI, and this is definite. But for others, I think it is the quality of the fluid rather than the quantity of the fluid is more important. And recently, we have published a study about, for example, the gamma cassia and its effect as a probiotic on the intestinal dysbiosis and the microbiota of the gut. So it is not the quantity as much as it is the quality of the fluid that the patient is taking, I think. That's why if you are not at the limit of dehydration, it is accepted. And this takes to the point of the intermittent fasting. Actually, the intermittent fasting, the main mode of action of intermittent fasting is a stimulation of autophagy. And the stimulation of autophagy only occurs when intermittent fasting is complete intermittent fasting with no calories and even with no fluids. And this should be above 12 hours of fasting, and usually it does not entail night over daytime. It can be either or.
Thank you. Professor Hosam, we have a question about omitting the night dose of insulin from Professor Dalia Rojdi. I think there is some do this about omitting the night dose of insulin of the patient taking dose, suhoor dose of insulin. What's your opinion?
Yes, regarding the human insulin, which is the famous one, the NPH in the human insulin is usually lasts for 16 hours. So if we omit the suhoor dose, usually the period from the Asr to Al-Maghrib, usually the patient is not having insulin. And usually this is accompanied with a hyperglycemia in the pre-iftar area. So as I said before, we should not try to fast with those regimen in Ramadan at the first time. We should advise our patient to try in Rajab and Shaban because it is a trial and error. For example, I'm taking 60 units before iftar in the morning. I will take it in the same in Ramadan, and I take 40 units, so I take 20 units. But if the patient is taking 20 units, he is developing hypoglycemia, for example, at 4 p.m. So I will advise him in the next time to take 15 units or 12 units. So everything is okay. On the other hand, this is not a rule. For example, the patient is taking 20 units and at Al-Asr, his blood sugar is 280 or 300. So in the next time, I should advise him to increase a suhoor dose. So I not recommend if the patient is taking pre-mixed insulin twice daily, I'm not recommend him to take it once daily. I should take at least 30% of the dose at suhoor to make sure all time is covered by the insulin.
Thank you, Professor Hosam. Professor Hisham Saib, please has a comment, please.
Thank you very much. I would like to thank as well Professor Dr. Ahmed Korea, very comprehensive, and we will distribute to our group. I would like just to ask 2 questions. I don't exactly know the correct one. Medullary injury during prolonged fasting is probably due to medulla, like brain cells, almost use glucose for energy. So do you have any data suggesting that what type of injury of the kidney during prolonged fasting or not? This is my first question. My second question is one of the probable natriuretic effect of prolonged fasting because of the sodium glucose co-transporter and no sufficient glucosuria. So natriuresis and control of blood pressure during prolonged fasting. So if you please, you can comment on my two questions.
دكتور هشام جزاك الله خير على السؤال. بالنسبة للميدالري injury, it occurs from hypoglycemia rather than from fasting, and it's well known that not all fasting causes hypoglycemia.
Exactly.
If the patient is DKD, this is another issue because definitely the gluconeogenesis is lost within the kidney as well, and this might affect the total sum of glucose produced during fasting, and that's why fasting might be harmful in this situation. But if the patient blood sugar is maintained as at an accepted level, medullary hypoglycemia is not expected to occur. This is the first point. The second point that yes, the issue of diuresis based on the balance of the fluid intake related to the antidiuretic hormone waves and rhythm could be deranged by the timing of fluid intake. And this might be the theory behind nocturia in CKD patients.
But I'm talking about natriuresis, not diuresis. No, natriuresis because of sodium drop because of low glucose filtered by the kidney. So blood pressure could be controlled during fasting by natriuresis effect.
You mean that fasting would regulate blood pressure further?
Yes, exactly. Yes, by natriuretic effect of lower glucose filtered and sodium glucose co-transporter.
Yes. This is the mechanism. Yes, that is proposed. Yes, but again, unfortunately, haven't been tested on a wide scale. But it's a hypothetical mechanism. Yes.
Okay.
Thank you.
Thank you very much.
Thank you, Professor Hisham. Professor Hosam, you have a question that about what about the peak of the peak of pre-mixed insulin 4 hours after starting صيام.
By the carbohydrates in suhoor. So usually we advise the patient to take a high fiber diet and to avoid high glycemic index food in the suhoor. Make some calories and some carbohydrates in the first hours after suhoor. So the peak of short acting and the peak of NPH is already covered by the endogenous glucose or from the glucose from the suhoor. As I said, it is a trial and error. If I'm taking 50% less, so this is usually most of the studies found that this is enough. But if it is not enough for the patient, I can increase, and if it is not causing hypoglycemia, I can decrease. We should also know that 6 hours after suhoor, and there is no carb are present, there is a hepatic glucose production and muscle glucose production. Either from insulin deficiency or from insulin resistance associated by the patient. So if I'm not giving the patient insulin at al-suhoor, and if he's not having insulin covering the period from al-dhuhr to al-maghrib, there will be counter hyperglycemia and more polyuria and dehydration. So for these reasons, we give the patient insulin at al-suhoor, not mainly to cover the carb, rather than to prevent the hepatic glucose production during the fasting hours.
Another question for you, please, in short, about if there is any allowance for sugary diets. Usually we take in Ramadan, kunafa or lataif or something like this. In short, please. To the point.
To the point, try to avoid. But if you will take, you can take it 2 hours after iftar, and you should pay al-tarawih in a mosque with a long بيصلي تراويح كتير يعني عشان تحرق calories, and you should
increase the dose of insulin, for example, if he's on insulin.
Yes, if the patient is taking short-acting insulin or he's taking premixed insulin or sulfonylurea, he should increase the dose. But I mean, he should. It is in the beginning and the end. It is from the total calories of the patient. It is better to be avoided, but if it's should be taken in a small amount, and you should decrease the carbohydrates in the iftar meal and in suhoor meal, and try to increase exercise in this day.
Thank you, Professor Ahmed. A question for you that about if dialysis dialysis time is usually after the iftar period. Do you change your recommendation?
By dialysis time after if the patient is having his dialysis after iftar, there's no problem. I mean, my recommendation regarding dialysis patient is clear. If the patient is on maintenance hemodialysis thrice per week, he has no residual kidney function, and he is tolerating well fasting, he can be allowed. He can be allowed to fast. Whether to do that during, if his dialysis is during daytime or during nighttime, this is according to the patient tolerance. Because I'm not afraid anymore about the residual kidney function, unless the patient has a comorbid condition that prevents him from fasting or endanger his life or risk of progression during fasting. So definitely, if it is by nighttime and the patient can fast during the daytime, he can do it, no problem. And I think a lot of our patients actually, because the point is, we are speaking about what we've been seeing for years and years with the patient. Patient insisted to fast. A lot of patients insisted to fast during the dialysis time. A lot of patients can't tolerate fasting during the dialysis time. And many of our patients do well during fasting. I would say that few of them as well improve their kidney function during fasting. Of course, with the early stage of CKD, not the late stage.
Okay, thank you. We have no more comments. And I think most of the questions in the chat have been answered, including those of short-acting insulin. One question that the ideal time of exercise, Professor Hosam, the last question.
After iftar.
After iftar, do you specify specific time after iftar?
2 hours. 2 hours after iftar.
Yes, this was it. So please, we have no more comments, and we answered all the questions. And please, Professor Ayman and Professor Ines, close this very interesting meeting.
I would like to thank at the end all the speakers, Professor Ahmed and Professor Hosam and Professor Ines and Professor Yasser. Actually, this is a wonderful night. Actually, it's as you see, it was a full-seated meeting, exceeding. I think we have more than 100 in this meeting, and both professors actually covered in a very elegant way all aspects of concerning fasting Ramadan, either in renal patients and diabetic patients. I really enjoyed the Professor Hosam lecture. It was very practical and full of informations, and actually full of guidelines that we should follow. And as you said, that we should keep it in our phones and in our office to guide. Thank you very much. I really enjoyed this night.
Professor Ines, please.
Thank you very much, Professor Ayman, for co-chairing this important session. Thank you, Professor Yasser. After working for 16 years in Ramadan, fasting in people with diabetes, the most important thing to say is لا ضرر ولا ضرار. والإسلام سامح جدا جدا جدا. فربنا بيحب إن رخصه تؤتى. ما نقدرش نأذي عيان وإحنا مش عارفين بالفعل إذا كان هيتضر ولا لا. Thank you very much. Thank you, Professor Ahmed and Professor Hosam for elegant lectures. Thank you very much.
Thank you very much. Thank you, Professor Ayman, for this very interesting night. Thank you, Professor Ines, for sharing us for this extremely useful night. And many thanks for our speakers, Professor Ahmed Elkeraie, as usual, a very excellent and interesting lecture, and Professor Hosam Ghazi. And we promise you to meet you next year, inshallah, earlier if we will do this meeting will be earlier time than today, including regarding Ramadan. Thank you all professors who shared us and for all attendees, and excuse me to close this meeting. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته. كل سنة وحضراتكم طيبين.
السلام
عليكم السلام ورحمة الله وبركاته. عليكم السلام ورحمة الله وبركاته.
وعليكم السلام ورحمة الله.